Hello and welcome to the Transition Podcast. My name is Maral Agababai. I'm a Junior Policy Officer at the European Health Management Association, and I will be your host for this episode. This podcast is part of the Transition Project, funded by the EU for Health program, which supports the development of training programs to equip healthcare professionals with the skills needed to navigate the digital future with a particular focus on oncology. Through a series of interviews, we explore how digital transformation is reshaping clinical practice and how targeted education and capacity building can close persistent skill gaps. In today's episode, we focus on a real-world implementation. How are digital tools actually being rolled out in cancer care, and how are healthcare professionals being trained to use them? We will be discussing about a national initiative in Ireland that offers an inspiring case study for the goals of transition. To help us explore this, I am joined by Grant Carroll, a clinical pharmacist deeply involved in the digital transformation of oncology care in Ireland. Grant has played a central role in the development and rollout of the National Cancer Information System. Grant, welcome to the podcast. It's great to have you with us.
Thanks very much.
Grant, to start the conversation, could you briefly describe your role within Ireland's oncology landscape and the origins of the National Cancer Information System, and to describe us what the strategic goals were to drive its development, and also how the system is currently being applied in a clinical practice?
Absolutely, and thanks for having me, Morel. So my role is within the National Cancer Control Program in Ireland, and we're a clinical program which is tasked with implementing Ireland's cancer strategy. So we have a fairly broad remit in terms of working with health service providers to prevent cancer, treat cancer, and increase survival and quality of life for those who develop cancer. And I guess the idea of having a national electronic system for the management of cancer was primarily early on focused on the management of medication. And it was really first mooted by oncologists and hematologists, and then subsequently it was included in Ireland's cancer strategy, which was really important for us to have a strategic basis for doing this piece of work. And what we were really looking to do was develop a single system that would provide the right information in the right place at the right time for clinicians, while also providing an electronic solution for the management of chemotherapy and then other medicines that are used to treat cancer. At the time, we were quite digitally naive in Ireland, and a lot of hospitals would have been using paper. So having an electronic system was thought to be a big advantage, and also then having a joined up system as well. So currently in NCIS, we're live in 22 of the 26 hospitals in Ireland that provide cancer medication services. And it's been used in different ways in different hospitals. But what we can see is that usage is really increasing of the system. And I think more importantly, what we're seeing is that the system's being used across different hospitals, which means information is flowing seamlessly between those different geographical sites.
Thank you very much for that explanation, Grant. It's definitely clear that the National Cancer Information System was created out of a strategic vision to unify and also to streamline cancer care through better information flow as well as medication management, if I understood it correctly. It's also very impressive to hear how it's already implemented in hospitals that allows to connect hospitals across different sites and to enable information to flow more smoothly. With that in mind, I would love to dig deeper and to understand what prompted the creation of NCIS. Was it perhaps introduced in response to a specific pressure or an insufficiencies within the cancer care services?
I think the initial prompt really came from clinicians, from oncologists and hematologists, and I think that's really important, because I think our initial drive came from doctors working in cancer service and looking to improve how you operated their services. So, and I think at the time around the world there were a lot of electronic systems in play in different parts of the world, and in Ireland we were fairly digitally naive, I suppose, in the sense that we were largely working off paper. So I don't think there was a specific driver in terms of an incident that happened or anything like that. But I think what there was felt amongst the clinicians was that, well, if we had an electronic system, if we could share information between hospitals in a more seamless way, then we can improve safety and we can improve efficiency. and we can make the workflows a lot better for our patients, and hopefully bring more. As we know, the incidence and prevalence of patients with cancer, there's a lot more treatments being completed, so the workload is ever increasing. So I think again it was that there wasn't a specific thing, but there was a sort of conglomeration of different factors that brought clinicians together to us to say, hey, if we could have an electronic system, if we could have it joined up, I think that we could provide better care.
Thank you very much. It's very insightful. And it's also very striking to hear how clinician-led the initiative is. It speaks volumes that the system's relevance, it speaks volume about the system's relevance to the real world practice. And of course, turning that vision into something that is usable across so many hospitals is also a huge undertaking. And you have mentioned before that NCIS is live in 22 out of 26 public hospitals, and provide cancer medication services. So I imagine rolling out a tool like this across that many hospitals is definitely not a small task. Can you tell me the how did you approach training healthcare professionals? And while doing these trainings, did you face any resistance?
Yeah, you're right. It's no small task at all, and we definitely encountered resistance. And I mean, I sort of, at the risk of repeating myself here, I think having a drive from clinicians, and then that specific strategic goal driven from that drive was really, really important. Because that means that it's a project that's being driven from clinical need versus sort of a top down or a bottom down versus bottom up versus a top down approach, I suppose. And I think in some senses, before we got to the training, what was really important for us was to have a good clinical governance around the project. And this sort of feeds into the training in that we set up a group which we called our implementation group. And that group was tasked with making decisions about how we configured the system, things like the drugs and the regimens. And that group included representation from consultants, from pharmacists, nurses, data managers, ICT, so everybody who would be involved with using the system. And then what we do is we can feed into that group from user experience, or in the early stages of the project, what the user expectation was. And then we could try best to make sure that configuration works as best it can for everybody. And I can't stress enough how important that was, and that we've really tried to make sure that NCIS is clinically driven and owned by the users of the system. And we in the national office really are just trying to bring those people together to deliver that as much as we can, based on clinical need. And then, so that I think fed into the training, because when we were training people essentially, hopefully, on a system that had been developed by clinicians certainly in terms of the configuration. And I suppose the training model that we used was a train the trainer model. So each hospital, during their implementation, we'd work through common workflows with super users within the hospital. So we'd identify users in the hospital who would be super users, who would be involved in the training going forward and the management of the system, with the intention that they would then train staff going forward, during the go live, and then also after go live on an ongoing basis. Because again, that's really important, that you don't just do your go live and stop. You think about how you're going to move forward from that go live. And then during sort of the early stages, what we do is we the national office would support hospitals. We provide webinars. Again, we try and do this in a flexible way. So some hospitals would like that once a week. Others would prefer a couple of intensive days with us on site. So again, trying to kind of marry that training with the individual hospital and how they could fit their workload around the training. And then what we do, so then the idea was we'd have those trainings, we'd have those webinars, we'd have a train the trainer session with our vendors as well. And then we try to then support the hospital as it's moving forward, as much as possible with ongoing training where we can.
Thank you very much for this comprehensive explanation. I was wondering, you have talked about the trainer models, and you have used the word super users. Can you maybe describe that a bit more? What does it entail? What is a super user in the trainer model?
So essentially, a super user is a user within the hospital who is, in many ways, they're the interface between us, the national office, and the vendor, and then the users within the hospital. So the hospitals would have different different numbers of super users. So some might have several. They might have a nurse, a pharmacist, and a doctor. Some may just have a pharmacist, or some may just have a nurse. But the idea is that the super user is essentially an expert user of the system within the hospital. And they are so important to the way the system works because they drive the implementation of the system. So they work with us in the national office, they work with the vendor in the early stages of the project to try and understand how the hospital's workflows will be managed when the system is in place, how they can adjust their workflows. They'll feed back to us and the vendor in terms of improvements and things like that. But I think in some ways their really key role is to be a champion of the project within the hospital. So their role then, of course, is to train new staff. And they may not do the training themselves. They may organise training sessions. They may have specific trainers within the hospital, but they're really the key point of contact between the national office, in our case, the vendor, and the individual hospital users. And then in terms of train the trainer, so the idea is that for a train the trainer approach is that, again, we, the national office and the vendor, would train specific super users to be the trainers in the hospital. So there's not a reliance on the national office always doing the training. And I think what that allows is flexibility within the hospital as staff change and move a lot. The hospital itself can provide the training. They're not reliant on national office as well.
Thank you very much. And you have also mentioned that webinars have been used as a training module to help the healthcare workforce to use the tool. So I'm wondering, the webinar, is the webinar also clinician-led, or does it come from NCIS?
So the webinars are generally run by the national office. Now, to be fair, the national office we have a lot of clinicians within the national office. So most of our project managers would have clinical backgrounds. I'm a pharmacist by background. We have a good few pharmacists. We've nurses. We have people who are radiation therapists. So people who've come from that clinical background. So what we tried to do with the webinar series was look through the workflows, because obviously cancer care is a pretty complex workflow, and our system runs right from the ordering of medication right through to administration, so includes the pharmacy side as well. So what we tried to do was break down the workflow into steps, I suppose, and I think we come up with about 30, and then we essentially have 30 topics that we need to cover prior to our implementation. And as I said, like some hospitals would we offer it as a webinar series, but yeah, we can also go into the hospitals and deliver them in person if that's something that the hospital wants. But I think the beauty of webinars for us, and this was something we kind of discovered through COVID, was that the webinars allow both the hospital and the national office to have a bit of flexibility. So we can deliver the webinars wherever we are, whenever we need to. So if the hospital wants to have them once a week, we can do an hour once a week. But if they would like to have 2 full days where we go down to the hospital and run through them, so they're not really webinars then, they're more in person, but it's the same content. But I think the key is the content, actually, that we have those 30 key topics or whatever it is that we need to cover, and we can cover them either via webinar or we can cover them in person. But we can be flexible because every hospital has different challenges and different difficulties in terms of their workflows and their workloads. So it's helpful that we can be flexible, I think.
That's very interesting to hear, that the training in general is a very flexible program, that it is genuinely made for the healthcare workforce. And it's very interesting to hear how central implementation has been, also not just for the system configuration, but also to ensure that every clinical voice is represented, actually. And even with that structure, and also with the structure that you have just described to us with the webinar and the trainer model, I imagine that the rollout still revealed some gaps. So I'm wondering, what kind of digital skill challenges did you notice during or even after the implementation? And where do you think clinicians still need more support when it comes to digital literacy?
I think probably what we see when we go into hospitals is that there's sort of like a few people in the hospital that are a bit techie, for want of a better word. And they often end up being the super users, actually. And I think those people aren't necessarily really have a lot of technical knowledge. They're not necessarily, but they tend to be interested in how technology can help their workflows, and they're willing to learn and help their colleagues adapt to a new technology. So I think those people are really important. But I think perhaps as time goes on, there's sort of more techie people as some of the younger doctors and nurses and pharmacists coming through are sort of digital natives. So I think that kind of comfortableness with technology is increasing. But I think what we see in the majority of people maybe is that they have a really good understanding of what they do each day. You know, they're very, very good at their workflows. They're prescribing, they're giving chemotherapy. And what they need is that technology to support them and not hinder them. But I think what we see then is these people, for a lot of people, the challenge is their nervousness around technology. So they perhaps not so used to using technology in their workplace because they've been working off paper for so long and they're so comfortable with the way that they're operating that bringing in a piece of technology is always going to change their workflows. So a lack of understanding of technology, it's more, I think, a nervousness around how it's going to impact the way they work and how the technology is going to slot into their existing workflows, and how it might force them to change, I think.
That's very interesting to hear because you've just highlighted the challenges such as unwillingness or nervousness because of the changing workflows. I'm wondering, I believe that this is maybe the most observed challenges that has been, but of course, it has been observed during the rollout. But has there been any other challenges that could be just as important as nervousness and unwillingness to technological or digital tools?
I think one of the other challenges then is the changing in workflows. So I think that it's often, it's important to say that when you bring in an electronic system, you can't necessarily just slot it in on top of the way you work now. The electronic systems, it's designed by vendors who are working off workflows, and very often, I mean, I think always actually, to use an electronic system well, you need to refine your workflows as well. So it's going to be so I think that challenge of bringing in an electronic system and then understanding that there will be a need to change workflows, and that actually, if you kind of stick with it, eventually it'll start to work through. But it's that very initial feeling of unwillingness to change a workflow that's really well established on paper, and then trying to wedge the IT system into that existing workflow rather than looking at the IT system as an opportunity to refine and change those workflows. And I think that's when it's really important to have that interface between the project team and the vendors to listen to the users as well. So there can be changes to the product, but there can be changes to the workflow as well. And it's a real balancing act, I think, which is a very difficult thing to get right, to be honest.
Thank you very much. It's very, very insightful. And given all the challenges that you've just highlighted, it's very clear that there's a pressing need for more targeted training solutions to enhance the digital literacy, as well as for healthcare workers to be more confident working with digital tools. And it's precisely this realization that has triggered our involvement in the consortium led initiative, which is called Transition. Just to have a brief overview of what Transition is, Transition is an EU financed project that is led by the Cyprus University of Technology and has developed and circulated a wide range of certified training modules aiming to strengthen the digital skills of healthcare professionals from electronic medical records to the diagnosis and the treatment technologies. Based on your experience, where do you think a project like Transition could have had the biggest impact? Would you think that the main value would be in improving how training is designed or supported on the ground implementation, or maybe in helping to harmonize the systems across hospitals?
I think transition's really, really valuable. I think there's a couple of elements where it'd be really useful. I think in terms of that, just digital awareness and kind of understanding how a digital project is implemented. I think for a lot of hospitals, it's very new in terms of this implementation of digital systems. So having an understanding of the process around implementing a digital system, of developing a digital system, I think that's really important. So I think transition can be really useful in terms of passing on that information, in terms of giving a framework for example, a train the trainer model. How would that work? How does a train the trainer model look if you're coming into a hospital? So that clinicians already have some experience or some understanding of how the model will work going forward. So I think that's one example of where transition can be really helpful, perhaps laying out some different ways in which projects can be implemented within hospitals as well. And I think one other thing that could be useful is hospitals having an understanding of the digital landscape. So how vendors go about developing their systems. What are the advantages in bringing in technology, but also what are the disadvantages and what are the challenges? And if they can see that the challenges that they're experiencing locally are actually challenges that a lot of hospitals have experienced, a lot of healthcare settings have experienced, and they're not unique to them, I think that helps, because I think that helps you understand that you're not in a particularly unique situation, and there's nothing wrong with what you're doing. It's nothing wrong with you feeling nervousness or feeling that the change of a technology is difficult, because it's difficult everywhere. And then I think the other thing maybe the transition can do is can show the successes as well. So that, there are examples like the National Cancer Information System in Ireland. There's lots of examples around the world of where systems have been implemented in lots of different and buried and complex healthcare systems, and they're working really well. And they've been through those challenges and they've got out the other side of it. So it is possible to do these things.
Thank you very much for such a comprehensive answer. And I agree with you that it's very vital for hospitals to understand the digital landscape. And it's also very much vital that clinicians need to overcome nervousness to turn technology into a real opportunity rather than just see it as a burden. And I also agree with you that programs like Transition, they can play a very important role in building that confidence and unlocking the true benefits of digital tools and not just the burden that comes with it. Well, thank you very much, Grant. Before we wrap up, is there anything else you would like to highlight or share with the audience?
I think I'd just like to say that, we've undertaken quite a big IT project in Ireland. Joining up a fairly disparate health system in terms of that information was very difficult. We had to do a lot of standardization work. It was a big change for a lot of hospitals, really moving from paper to electronic. But what we have seen is we've seen that it can be done. It was quite difficult. There were many times where we probably thought maybe we shouldn't do this. This is too hard. But I think by persisting, by making sure that you have really clear governance and making sure that it's a clinically led project, I think has been one of the key things to our success, is that we have tried, and it's been, and I don't think we get this right all the time, but we've tried really hard to make sure that we listen to the people who are using the system, the clinicians, and we've tried to do things like adjust our training so that people can attend in a way that works for them. We've tried to provide training tools that are useful for them, and we've tried to adjust our configuration based on the ask from clinicians and having that clinical governance around doing those things. So I think I can't stress enough the importance of the governance and the system being clinically led. I think that really helps these difficult projects move forward and ultimately leads to acceptance of them, which is the key thing.
Thank you very much, and I couldn't agree more with you. I think that actually wraps up today's episode. Our sincere thanks go to Grant Carroll for sharing his insights on the digital transformation of oncology care in Ireland. Your experiences have really drawn attention to the complexity of national digital rollouts and the need for practical training that genuinely supports healthcare professionals. One point that really stays with me is that developing advanced digital tools is just one part of the equation, but equipping healthcare teams with the right skills to effortlessly use them is equally essential. So, thank you all for listening, and let's not forget that the real driver of digital change is the people who bring it to life. Thank you very much, Grant.
Thanks, Mara.